Hello everyone, this is Dr. Hashem Abu Serhan. I am here today to talk about one of the interesting lectures about Humphrey visual field. Our topic today is the interpretation of the Humphrey visual field printout. Please be prepared, focused, and stay tuned. We'll explain everything from scratch. So our strategy in this lecture is like Sukupan puzzle game that will talk about every small detail until the full picture form and you see all the details explained together. So please be patient and wait for the final result. So we will start our topic today by defining the visual field. The visual field definition is the area that is perceived simultaneously by a fixing eye. It's a three-dimensional, not two-dimension. As there is a common definition, Trackware definition, which is small village in Scottish borders. Trackware definition would say it's an island of vision in a sea of darkness. It's like a way of visual analogy where you see that there is center of vision surrounded by area of darkness, which is the area that you don't see in the periphery. So this island represents the maximal visual acuity in the fovea, which represent the hell of the vision, and then the sensitivity, visual sensitivity reduced by going to periphery. It has limits: superiorly 50 degree, inferiorly 70 degree, nasally 60 degree, and temporally 90 to 100 degree. And you should know that the blind spot is 50 degree temporal to the fixation point, where the optic nerve exits from the retina. So going back to basics, we have the isopter, which is a line in visual field connecting points with the same visual threshold and encloses an area within which a target of a given size and intensity is visible. So we should understand these terms in order to understand the visual field printout fully. What is the difference between scotoma and visual field effect? Scotoma is absolute or relative decrease in retinal sensitivity within the visual field, bounded, very important. This is the differentiation from scotoma to visual field. Scotoma is absolute or relative decrease in retinal sensitivity within the visual field, bounded by areas of normal retinal sensitivity and could be positive or negative. The positive, where the patient reported that he don't see specific point in the visual field, which is the scotoma, or negative, that the patient cannot describe it, but we discovered it during the test. Versus the visual field defect, which is absolute or relative decrease in retinal sensitivity extending from the edge of the visual field, which means that it's not surrounded by areas of normal retinal sensitivity. And to make it more clear, this is the scotoma, where its reduction, either absolute or relative, in retinal sensitivity surrounded by areas of normal retinal sensitivity, and here is the visual field effect extending from the edge. Going to the difference between luminance and visual threshold. Luminance is the intensity of the light, and the absolute unit of the luminance is the apostle, ASP, which is we usually see in the visual field printout. That's why I put this information here to understand everything in the visual field printout. And the normal human range for the luminance is from 2 to 9,000 apostle. And regarding Humphrey visual field, can test from 0.08 to 10,000 apostle. However, the decibel is the relative unit of luminance, is the inverse log scale. And when you see the higher the luminance, the lower the decibel. 10,000 apostle equal 0 decibel, and 1 apostle equal 40 decibel. Regarding the visual threshold is the luminance of stimulus which is perceived 50% of the time. The brighter the stimulus needed to be perceived, the lower the visual field, and vice versa. The less brighter or the dimmer the stimulus, the higher the visual field. So the brighter stimulus means higher apostle and lower decibel and lower visual threshold. This is very, very important kind of formula to understand. Regarding the stimulus size, we see in the uh, Humphrey printout this number, the Roman numeral number 3, which what what is what is the indication of this number? We'll see. This is a convention introduced with Goldman perimetry, and we'll talk about a little bit between the difference between Goldman perimetry and the Humphrey visual field, and it's numbered with Roman numerals from 1 through 5, and each stimulus covers 4-fold greater area ranging from 125 millimeter square for a size 1 stimulus to 64 millimeter square for size 5 stimulus. The most common used stimulus size for Humphrey visual field is stimulus size 3, which corresponds to area 4 millimeter square. So this is the most important thing to understand, that the size used in the Humphrey field analyzer is stimulus size 3, that is corresponding to 4 millimeter square. Sometimes stimulus size 5, which represents 64 millimeter square, can be used for severe visual field loss or patients with poor visual acuity. So, coming to the perimetry, which has very, very rich history and long-standing, well-established trajectory. Perimetry is the quantification. It's the process of where you quantify the visual field. It has been classified into two main branches. The first one is campimetry, which is flat surface, and one of the most popular examples of campimetry is tangent screen, which is manual and kinetic and tests the central 30 degree, and usually the subject seated 1 or 2 meters from black screen, and the target is presented by the examiner. However, the other branch of the perimetry is the perimetry, which is curved surface, and there are common examples, which is the laser screen, the Goldman Powell perimeter, and the Humphrey visual field analyzer. For the laser, it's manual and kinetic and extend beyond 30 degree toward the peripheral field. And for the Goldman Powell perimeter, it's manual and kinetic or static, and there is hemispherical pole with a radius of around 33 centimeter, where the subject sit also at 33 centimeter, and it has stimulus size ranging from 1 to 5 and stimulus intensity ranging from 1 to 4, and we said this is the convention that is introduced by Goldman perimeter, and it's testing not only the central 30 degree, it extends beyond the 30 degree, including the peripheral field. However, the Humphrey visual analyzer is automatic, static, and tests the central 30 degree, and we'll explain this in details in the following slides. As we said, Humphrey visual field analyzer is automated static perimetry. Very important to know this information. Testing the central 30 degree. So, what are the advantages of automated over the manual compared to other perimetry that we talked previously? It's more quantitative, there is no examiner bias, and there is constant monitoring of fixation and automated retesting of the abnormal points along with computer software for the analysis. And what are the advantages of static over kinetic? It's also more quantitative, more objective, more sensitive to shallow scotomas, and there is random presentation stimuli, so there is less anticipation from the patient, and it's also faster. As we said, these are the basics of the Humphrey Visual Analyzer. It's automated static perimetry. It uses what we call standard automated perimetry or achromatic automated perimetry, which is white on white, which means that it introduces white stimulus on white background. And the stimulus size is the Goldman size 3 with the duration 0.2 seconds. And the background illumination 31.5 apostle, and the maximum luminance predicted by Humphrey visual field is 10,000 apostle compared to the Goldman visual field 1,000 apostle. So you should now understand what are the meanings of apostle, what are the meaning of stimulus size, what is the meaning of white on white or standard automated perimetric SAP. So we are like a puzzle, filling the gaps until you see the full picture. So please focus with us. For testing strategy, we have in the original visual field 4 test strategies. The full threshold strategy, which follow the 4-2 bracketing algorithm at each retinal point. What is the meaning for 4-2 bracketing algorithm? The stimulus intensity increases in 4 decibel steps until the threshold seen by the patient, until the stimulus seen by the patient. Then the threshold decreased in the stimulus intensity in 2 decibel steps. So you have increase in 4 decibel steps until the patient see, then you start decrease the intensity of stimulus by 2 decibel steps. So it's called 4-2 bracketing algorithm. Also, we have related strategy which called full threshold with prior data, which by the title uses prior visual field data, so it's faster and present each point 2 decibel higher than the patient previous threshold value and test each point in 2 decibel decrement. And we have also the faster threshold. This is even faster and present the entire field at 2 decibel higher than the patient previous threshold values and then test only the abnormal points. And also we have the supra threshold test strategy, which is fast screening test and presents stimuli as 6 decibel higher than the expected threshold, and each point then is recorded as normal versus abnormal. But nowadays, the most common and the standard method for assessing the visual field in glaucoma patients or in Humphrey visual field is CETA. CETA, which is the Swedish interactive threshold algorithm. It's very, very clever algorithm where it analyzes the patient responses and uses age normalized statistical data to shorten the testing time. So the main aim of CETA was to increase the speed without losing accuracy. How it works, it provides smart questions, smart pacing, and all the factors during the test are considered, trying to produce estimated threshold at each point using normal age corrected threshold value as a starting point, and they have calculation where they do during the test recalculation of the threshold values and uses all information from every point in order to shorten the period of the test without losing any accuracy. We have the CETA standard and we have the CETA fast, which only takes 4 minutes per eye, and we have even the CETA faster. And for the CETA standards, like the full threshold strategy that we talked about in sensitivity and accuracy, however, it's twice as fast, twice faster than the full threshold strategy that we talked about previously. However, the CETA fast, it's like the supra threshold algorithm in sensitivity and accuracy, but twice as fast as the supra threshold algorithm. Takes only 4 minutes per eye, as I said, but it's less accurate and sometimes underestimates scotomas, and actually some Some recommendations say that it should only be used for patients with mental and physical limitations, preventing them from using other strategy. However, in very, very busy clinics, CETAFAS is very common to be used. Some like Forge recommendation, they are saying don't use CETAFAS for patients for glaucoma screening or follow-up of progression. Coming to the test patterns, we have three main patterns in visual field. So the first one is the 30-1 or 30-2 test patterns, and we'll explain why it's called -1 or -2 just in a few minutes in the following slides. However, for the first number 30, because it's testing the central 30-degree of the fixation, so this is the fixation point, it will test the central 30-degree of fixation. It's very common use for neuro-ophthalmology clinics or for any neurological complaints, because it's testing wider peripheral field compared to the 24-2. And this test, as we said previously, that Humphrey visual field tests the central 30-degree of fixation versus in contrast to the Goldman visual field would extend beyond the 30-degree, reaching the peripheral field. The second most common used test patterns is the 24-2. And why it's called 24? Because it's testing the central 24-degree fixation. So it will test the central 24-degree fixation. However, nasally, it tests 30-degree, not 24-degree of fixation, in order to catch any nasal steps seen in glaucoma, in early glaucoma. And this is why you don't see it like a complete regular circle. You see it like there is a tail, and this is the tail representing the nasal 30 degrees. And very common use for most glaucoma patients, and usually this is the most commonly used test pattern, 24-2. Coming to the 10-2 test patterns, where it tests the central 10 degrees of the visual field and test points every 1 to 2 degrees. Sometimes, if you want to test the central field in advanced glaucoma, instead of using the 10-2 test pattern, you will use size 5 stimulus. Can be used, as we said previously, in advanced visual field loss or poor visual acuity, like this. However, 10-2 test pattern can be used for advanced visual field loss or with paracentral defects, and focus on this point, because many doctors, many ophthalmologists believe that 10-2 test patterns only used for advanced glaucoma. However, it can sometimes help in detecting the early paracentral defects seen in glaucoma patients, and we'll elaborate more on this point in the following slides. And it's usually typically used for macular diseases like hydroxychloroquine toxicity or advanced glaucoma. It's noteworthy to mention that, as we said, the optic nerve is 50-degree nasal to the fovea, so this is why the physiological blind spot doesn't appear on the 10-2 test pattern. The rule of 10-2 visual field in early glaucoma. As we said, many doctors, many ophthalmologists, many surgeons in ophthalmology, they believe that the 10-2 visual field importance coming only in advanced glaucoma to follow up the progression of them. However, there is some rule and there is evidence to use the 10-2 visual field even in early glaucoma suspect and moderate glaucoma. And why is that? Because the 24-2 and 30-2 threshold visual field testing strategies assess around a total of 54 and 74 points respectively. So the 24-2 test patterns assess around 54 points, 30-2 visual field testing pattern This is around 74 points, and each one is 60 degrees apart, 3 degrees from the horizontal and 3 degrees from vertical meridian. And there is only of these points 12 points tested within the central 10 degrees. And out of these 12 points, only 4 points testing the central 8 degree macular region. And this 8 degree macular region accounts for over 30% of the total retinal ganglion cells and over 60% of the visual cortex area. In contrast, on the other hand, the 10-2 threshold visual field testing strategy assesses 68 points, 5 times as many points in the central 10 degree compared to the 24-2, 30-2. And we'll see this on very good image. So this is the figure. See here in the 32-2 test strategy, there is 72 points to be checked. And out of these 72, there is only 8 points, 1, 2, 3, 4, 5, 6, 8, in the central macular area, which represents 30% of the total retinal ganglion cell, and very important area. Compared to the 24-2, where it's checked around 54 points centrally and around only 4 points in the central macular area. Comparing, see here, in the 10-2 visual field, there are 68 points checked in the central 10 degree, 5 times higher than the 24-2 or 30-2. And this is why, if you see here, one of the examples of glaucoma patients, in 24-2 there is a loss of the superior, there is a loss of the inferior retina, and this is Hood glaucoma report. Because this is the points tested in the 24-2, this is how the visual field came. However, comparing to the 10-2, where it tested more heavily the central 8 degree macular area, this is how the field in reality. So this field much worse than this field. So you can underestimate the field effect in 24-2 on those patients. And not only that, if you see, we have 3 scenarios where in the 24-2 the defects were like this, following this pattern, and also here will be abnormal in both fields. However, what will represent the reality is the 10-2 visual field, like this picture, the before picture we show, compare the 24-2 visual field. However, if there is here normal in the 24-2 field, it could be abnormal. The 10-2, there is only these points have been lost in the glaucoma, in early glaucoma. So in these situations, you will find normal 24-2, however abnormal 10-2. And this is the importance of doing 10-2 abnormal in early glaucoma, or even if in patients with a strong history and high suspicion for having glaucoma. However, the 24-2 is normal. And the final scenario where the points outside the central macular area, where the 24-2 will be abnormal and the 10-2 will be normal. So both of them are important, and both of them you should use them very carefully. And not only that, I will here in this slide mention the evidence behind that. I have listed around more than 5 studies talking about the role of 10-2 visual field in early glaucoma. For example, Grants, who first found illustrated how the central visual field could be affected in early glaucomatous damage, followed by many studies. One of the study, Teixeira and his team reported that more than 50% of eyes with mild to moderate glaucoma had defects within the central 3 degrees. And not only that, Hood and his colleagues found that 9% of normal 32-2 visual field glaucoma suspects turned out abnormal with 10-2 testing. And De Maurice found that 11 eyes with normal 24-2 visual field outside the central 10 degrees showed acute defects within the central 10 degrees in 10-2 visual field. And Sullivan and his colleagues reported that 6% of eyes without 24-2 field loss showed a 10-2 defect. So it's clinically evidence proven. So please don't believe the common mistake that or the common misconception or misunderstanding that 10-2 visual field use only in advanced glaucoma. No, it can be used even in early glaucoma or glaucoma suspect, as we said. 9% of normal 32-2 visual field glaucoma suspect, they turned out abnormal with 10-2 testing. So now, why is called dash 2? As I said previously, I will explain every detail in this printout to be fully understandable by you. So, dash 1 or dash 2 represent the patterns, the way of how these points tested. So, the first pattern, which is dash 1, represent the first pattern. They used to present the stimuli directly on the x and y axis, and it has been replaced a long time ago. The main drawback why it has been replaced a long time ago, because the midline points don't show which side is affected. I will show you a picture explaining this point more clearly. However, the dash 2 is the second pattern for this threshold test that was developed. It has been improved to present the stimulus or the stimuli 3 degrees away from the x and y axis. If you see this point, this is 30-1. Here, they are presenting the stimulus exactly at the vertical and horizontal meridian at the x and y axis. However, 30-2, the second pattern, they will start not on the meridian itself. No, they will just start a little bit beside that, so they can know which side of the field is exactly affected and don't miss any points. So you understand now why it's called dash 1, dash 2, and we are using now dash 2. So, coming the impact of glaucomatous visual field loss. Why we are studying the visual field in glaucoma in general or other diseases? Because patients with visual field loss in glaucoma, they are at increased risk of car accidents. And some studies found that patients with moderate or severe field loss in the worst eye had approximately 4 times greater risk of being in a car accident than patients with no visual field defect. And because of the visual field loss, many patients with glaucoma avoid difficult driving situations. And also because of the visual field loss, glaucoma patients are at increased risk of falls. So if there is increased risk of car accidents, if there is increased risk of falling, there is avoiding difficult driving situations. So it's very important to understand the visual field in glaucoma patients. As we introduced and explained the 5 rules, the 5 R's for the assessment of optic disc in one of the previous lectures that I have uploaded in YouTube. So please go there and watch this lecture. It's very useful for you to completely and fully assess the optic disc systematically and comprehensively. So just as a way of revising and connecting the two lectures together between the clinical and investigation part. So in order to know is this the disc glaucomatous or no, you should use these 5 rules. The first rule that you should observe the scleral ring in order to identify the limits of the optic disc and the size of the optic disc. Then you will identify the rim, what we call it the isn't rule. Inferior should be the thickest, followed by superior, then nasally and temporal rim. Then you will examine the surrounding retinal nerve fiber layer, if there is any localized, wedge shape defect or diffuse RNF layer defect. Then you will examine the parapapillary region to see if there is any alpha zone or beta zone atrophy. Then you will look for any retinal or disc hemorrhages. By examining these 5 rules, you can clinically diagnose many patients with glaucoma without using an investigation. Coming now to presenting the 5 R's, the 5 rules in the visual field interpretation. And I would like to thank the popular lecture on this topic, the Forge lecture focusing ophthalmology and reframing glaucoma evaluation, which has been done and sponsored by Allergan in 2013. So starting with these 5 rules, 5 R's, the first R is the right test, then reliability, then the review of probability plots, then the RNF layer patterns of loss, and then reaffirming the diagnosis. And we'll explain each rule in details in the following slides. First rule, be sure that the right test was used. So the right test, we should come across all these points. Check the strategy, check the similar size, the field size, the eye, the aid by confirming the date of birth, the pupil size, and the refractive error. We'll see here the OD, which means the right eye. We'll see here the stimulus size, so it's 3 and wide, background 31.5 apostille, the strategy theta fast, pupil diameter here it's missing, should be mentioned. It should be more than 3 millimeter, and visual acuity also should be mentioned. And here the refractive error +2, and here's the date of the test, the time of the test, and the age of the patient. All these should be confirmed before starting reading the visual field printout. Okay, so we'll confirm the right strategy by confirming the theta standard. As we say, theta fast, it's not recommended for patients with glaucoma because it can underestimate the scotomas. So ideally it should be theta standard, the Swedish interactive threshold algorithm. Here you will find the strategy theta standard. Then you will check the right test stimulus size was used, and we said that the Humphrey visual field analyzer used the Goldman size 3 as a standard. Sometimes you can use the size 5, as we said, for advanced visual field loss or decreased visual acuity. This is the 5Y stimulus in these cases, in the advanced glaucoma. Then you should check that the right field size, as we said, the 24-2 is the standard size, central 24-2 threshold test. However, 10-2, it's very important in advanced glaucoma to check the progression, and it's very important for visual field loss within the central 10 degree of fixation. As we said, like early glaucoma or glaucoma suspect, 10% of them will be having defects on 10-2 test strategy. Then you will check that the right age, the date of birth of patient has been reported. Why this is important? Because there is correction to the normative database. There's a Goldman table that adapted from the Humphrey field analysis instruction booklet. Depending on the age, they will correct for the refractive error. For example, if the patient is between 45-49 years, they will add +2 diopter sphere. And that's why they correct normative database. So very important, please check the age, check the date of birth for the patient. And also you will check the refractive error. You will see the refractive error, for example, for this patient having -1.25 diopter sphere. And also the correct pupil size more than 3 millimeters, because small pupils, meiose pupils, or people taking pilocarpine drops or any miotics agent will have small pupils, so they can block the peripheral stimulus, sometimes causing false peripheral decreased retinal sensitivity and therefore false peripheral field effects. So it's very important to check the correct pupil size. Here it's mentioned 3 millimeters. The second rule, coming to the second rule, we should check the reliability of the field. Is this printout reliable or no? By main 3 indices. These indices are the false positives and false negatives and the fixation losses. I will explain these 3 in details in the following slides, and you will see them in the printout in the up left side corner. Here you will see the details related to the brightness, and here you will see the data related to the reliability indices. The first indices is the false positive rate, which is very important indices to check that this visual field printout reliable. And it's the percentage of the time that patient responded in the absence of stimulus. And the ideal rate should be less than 10%. If you see false positive rate more than 33%, this is unreliable test. And you should be cautious when you see that the false positive rate more than 25%. Why? Because elevated false positives can artifactually improve the appearance of the field. And there's some patients, they just keep clicking, they calling them trigger happy because they keep responding in the absence of any stimulus. So this is very important. Reliability indices, you should always check it before reading the printout. And here you see false positive errors 2%. Ideally should be less than 10%. Coming to the second one, which is the false negative rate, the second reliability indices, which is the percentage of time that patient failed to respond to a stimulus that should have been seen based on past responses. So it's the false negative, basically, is a negative response with brighter than the threshold stimulus in previous tested points. So the patient will see a point, then the testing machine will show at the same location higher threshold stimulus. The patient should see it. However, the patient will not click, will not respond. And these seen especially in patients falling asleep, can reflect fatigue. And if you see it more than 33%, it's unreliable, and you should use it with caution in more than 25% false negative rate. However, some testing algorithms have no longer using the false negative rate index. Why? Because in advanced visual field damage, when you have visual field damage, the false negative rate will be high because of the variability in receiving the stimulus in these advanced visual field damage location. So they say that false negative rate sometimes can be not related to fatigue or falling asleep, but related to advanced visual field damage. So some tests, some doctors, they don't depend on it fully, but they depend mainly on the false positive index and the fixation loss that we'll discuss in the following slide. Coming to the fixation losses reliability index, this is the percentage of the times that the patient responded to a stimulus that presented at the plotted blind spot. And this is We call it Hale-Karakow method, where they present a point to the blind spot, okay, and the patient will respond. So there is no way how he respond to a stimulus presented at the blind spot. However, so consider as fixation loss. However, it has main drawback. We'll talk about it in the following slide. So fixation losses usually increase if the patient doesn't maintain fixation, keep moving his eye, the patient head moves, or the blind spot was incorrectly located at the beginning of the test. And this is the main drawback of the Hale-Karakow method, where they present a stimulus to the plotted blind spot. Because if you locate the blind spot incorrectly in the beginning of the test, this fixation loss measurements will be unreliable. And you should use with caution when you see the rate more than 20% fixation loss, and if you see that the fixation loss rate more than 33%, this is unreliable test. Okay, and here you see the fixation losses is 4 out of 15. So as we said, the original method was Hale-Karakow method, where they present stimulus at the plotted blind spot mapped in the beginning of the test. However, the main drawback that if you incorrectly locate the blind spot at the beginning of the test, this will increase the fixation losses falsely, and it will appear that the test is unreliable. So what Humphrey Visual Field did, they use what we call it gaze tracker, where they use infrared light in order to check the gaze stability throughout the test. And you will see at the bottom of the printout gaze stability line, you will see it like a line like that. Here in these points, it means that the gaze was stable. However, when you see it up, it means that the eye moved. So upstrokes means that there was increased eye movement, and if you see downstrokes, it means that there was lid movement. So this new technique by Humphrey Visual Field Analyzer is much better than the original method, the Hale-Karakow method, which depends on the blind spot. However, the gaze tracker depends on infrared light that follow and control the gaze throughout all the tests. We have other indices, just other clues that this test is not reliable, is unreliable. But these points are just clues that help you to understand the full printout. So short-term fluctuation. Short-term fluctuation means that they retest 10 pre-selected points and then they calculate the difference between the original test and the retest threshold. So first they will select 10 points that the patient answered to them. Then they will retest these 10 pre-selected points, and then they will calculate the difference between the original test and the retest threshold. And if they see that the difference more than 4 decibel, so this means that the short-term fluctuation increase. And this measures the consistency and indicator of reliability. And also can be one of the early signs of glaucoma. Sometimes the patients see it and sometimes doesn't see it. So as we said, this short-term fluctuation, one of the indicator of consistency and reliability. If it's increased, there is suspicious. However, the CETA algorithm doesn't calculate the short-term fluctuation. Okay, we have what we call corrected pattern standard deviation to the short-term fluctuation, and this corrected pattern standard deviation, we'll talk about the pattern standard deviation the following slide. The pattern standard deviation will be corrected to the short-term fluctuation, and it measures the localized variability, the localized irregularity. So if you see a high corrected pattern standard deviation, it means high localized irregulatory and highly suspicious for glaucomatous damage. And in octopus, not in Humphrey visual field, care always must be taken when you see the reliability factor value is more than 10%, which is mainly depending on this short-term fluctuation during the test. So it's like intra-test variability. Not only that, we have another or others reliability indices. The reliability is low when there is more than 550 stimulus are projected, or when the test takes more than 18 minutes. Usually, to determine the threshold for one test location, 5 stimulus are needed. In patients with field defects, more stimulus is needed. So if you see that the stimulus more than 550 are projected, or the test takes more than 18 minutes, it means that the reliability of the test is low. Always we have very popular field defect on the grayscale map in the visual field printout representing reliability index, the cloverleaf pattern. If you see this cloverleaf pattern, it means that the patient becoming fatigable, inattentiveness with time. And I will talk about it just in the following slide. And also, if you see increased eye upstrokes or lid downstrokes movement on eye tracker line or the gaze tracker line, it means that there is some unreliability because of the fixation. So this is the unreliable field because of the cloverleaf appearance, which means that the patient becoming fatigable, becoming inattentive, becoming doesn't concentrate, losing concentration. So they will test in the beginning of the test very well. However, when they coming with time, they will lose concentration, lose energy and motivation to respond well. So this appearance of the field like cloverleaf, it will show. So the 4 primary points around the fixation are checked and confirmed. If you see, then here you will see this is all field doses. This cloverleaf patterns means that the field is unreliable. So rule number 3, review the probability plots. Coming now to the global indices, the most important one, and we'll talk about the two important global indices. The first one is the mean deviation, the MD, which is from just the name, you understand that it's talking about the mean, average, and deviation. So it's the average loss of the entire field in decibels. Or in other ways, the depression, the loss from compared to the age normal halo vision. As we said previously, the halo vision is like conceptual model to understand the visual field, normal and abnormal perimetry, representing the hell. The maximum point of the hell is the fovea, where there is the maximal visual threshold sensitivity. And when you go to the periphery, there is reduction in this retinal sensitivity to the threshold, to visual threshold. And if you see in a glaucoma patient, they will start losing in periphery. However, in patient, for example, with optic neuritis, will start loss of the central hill of the vision. So, if you see this average loss of the entire field decibels compared to the age normal corrected data, give you the mean deviation. And for example, if you have a patient with minus 4 decibel, it means that it has on average 4 decibel loss less than the normal age adjusted population. It means that he has 4 decibels depression at all points in the field, or depression of 8 decibels over half of the field. Both of them would give MD or mean deviation of 4 decibels. The most important point, this one, the more negative MD, the more worse field. So if you see here minus 10, it's not like minus 1 decibel. And this probability, the p-value is the probability is given for that MD would occur in normal individual. So this MD, for example, it can happen in less than 5% of normal individuals. And if you see it 1%, it means that this MD mean deviation can happen in less than 1% of normal population. So 99% of this MD having abnormal result. You understand what is the meaning of p-value? It's like p-value in research. Coming now to the second most important global index, which is the pattern standard deviation, which is a measurement of focal visual loss. So it's a measurement not of global, of focal field loss, which means that it's the standard deviation of each point from the age-corrected normal, and it measures the variability or local irregularities of the field. The more positive, the more bad. Not like the MD, the more negative, the more bad. Here, the more positive, higher pattern standard deviation means higher variability, higher irregularity in the field, which means there is localized field damage. And in the ocular hypertension treatment study, the PSD, the pattern standard deviation, identified as one of the out of 5 important contributors to the risk of developing glaucoma. However, this pattern standard deviation in normal patients or severely affected visual field, they will have low pattern standard deviation, because in advanced glaucoma, as we say that this PSD, the pattern standard deviation, can decrease because the damage is no longer focal. It will be all the field reduction. There is like a generalized reduction in the visual field, like tunnel vision. So because there is no localized irregularities because of the advanced loss, the pattern standard deviation will be low. However, in general, the higher pattern standard deviations means the greater localized field damage. As we said, coming to the numeric results and grayscales, these are the numeric results and corresponding with a map, grayscale map. We have threshold sensitivity map. This threshold sensitivity map, it has numerical threshold sensitivity of each location by decibels. And this one, the map you should depend on. And this corresponding grayscale map should be used for education for patients. And the higher the threshold value, or the brighter the grayscale, means the higher sensitivity. So if you see blackish, the grayscale means that the patient has low sensitivity. Okay, the higher the threshold value, it means the brighter the grayscale and the higher sensitivity. These probability plots divide into the total deviation and into the pattern deviation. And we say that we should depend on the numeric plot, not on the grayscale. Grayscale should only be used for patient education. So these are the total deviation and the pattern deviation. And the total deviation like representing like the mean deviation, the MD point. The threshold at each point corresponding to the age-matched data, and the pattern deviation representing the localized irregularities like the PSD, the pattern standard deviation. So here the total deviation probability map or numerical probability map, and here is the pattern deviation probability map, and you will see along with the grayscale map and the bottom of the printout. Sometimes the grayscale and probability plots may not agree. That's why I told you should depend on the numerical probability plot, because this is the more accurate than the grayscale map. So this grayscale map, it can give you impression that this field is normal. However, when you see to the numerical probability plot, you will discover that this patient has a scotomas and field effect, and it's abnormal field, comparing to just looking to the grayscale map. So please look at the numerical probability plot. These total and pattern deviation are one of the most useful aspects of the automated perimetry. We said that they compare the field data of the patient respond to the normative age-matched database. They examine the depressed points. You should examine the depressed points. Not only that, the number of contagious depressed points, the location of these depressed points, and the severity of these depressed points. So always, please, these 3 points you should take in consideration when you see the total and pattern deviation map. So you will see first the number of contagious depressed points, the location of the depressed points, and the severity of these depressed points. And as we said, then you will look at the global indices. They will be on the right lower corner, to the mean deviation, to the pattern standard deviation, and to the glaucoma hemifield test. And we'll say what is the meaning of glaucoma field test in the following slide. You'll see here the mean deviation, the MD. You will see here the pattern standard deviation. The mean deviation, the more negative, the more bad. The pattern standard deviation, the more positive, the more bad. And this is the probability that this deviation is found in normal population. The glaucoma hemifield test, which is the third marker, which is very important in the global indices, evaluate the asymmetry between the superior and inferior fields. They choose clusters to imitate the anatomy of the retinal nerve fiber layer. Use these clusters, compare them between the patient hemisphere, between the superior hemisphere and the lower hemisphere, and to normative age corrected database. And they will say 3 responses. We'll talk about them: outside the normal limits, borderline, and normal. You see, for example, here the superior field compared to the inferior field, there is asymmetry difference between the superior field minus 20 decibel compared to minus 3 in the inferior field. So in the printout, you will see that the glaucoma hemifield test outside the normal, or borderline, or within the normal. They mean that the glaucoma hemifield test, or GHT, outside the normal limits, that the difference between the upper and lower defects not found in 99% with the glaucoma. That this difference is found in less than 1% of normal patients. And this glaucoma hemifield test in this patient is 99% abnormal. Okay? And if you see that the glaucoma hemifield test is borderline, this means that the difference is not found in 90% of patients without glaucoma. That this difference could be present in less than 3% of normal. Okay? However, the third result is the glaucoma hemifield test within normal limits. So combining the MD, the PSD, and the glaucoma hemifield test along with the maps, you will discover that this patient has glaucoma or not. We have last index is the visual field index. Okay, this visual field index is like a global index expressing the visual field as a percentage of the normal age adjusted visual field. Give greater weight to the points close to the fixation and less sensitive to the cataract. These are the main benefits, that less sensitive to the cataract and media changes compared to the MD and PSD. However, it requires a minimum of 5 tests over the 3 years. And despite that, it is less sensitive to cataract media changes, not immune to artifact. There's some artifacts can happen, like fatigue of the patient and other causes of artifacts in visual field. And also, the rates of progression, as we know, decreases as the glaucoma severity increases, because it looks like it reached the maximal reduction, so it will not appear on the visual field index as a rate of progression. So it's very, very useful marker to follow the progression of glaucoma patients in every stage of glaucoma. However, in the severe advanced cases, you cannot depend only on the visual field index as a marker of progression. But in general, it's very useful marker of progression. Number 4. As we say 3 rules. Now coming to the rule number 4, the RNF layer pattern of field loss. So please always look at the pattern deviation plot, and this pattern deviation plot should be consistent with the glaucomatous damage of nerve fiber layer bundle. So if you see here the pattern deviation of the retinal nerve fiber layer, the paracentral defect with nasal stipping, with glaucoma field outside the normal, and minus 3.6 decibels mean deviation, and 7 decibels pattern standard deviation, this representing glaucoma, moderate glaucoma. Also, as we said that sometimes the paracentral arcuate NFL defect may be very small to be seen in 24-2. Here the same patient, if you see here there's one scotoma, one field lost, minus 27 decibel. This is in grayscale map. But however, when you do 10-2, you will see that the paracentral arcuate RNF layer defect is much higher. Not only that, it's much higher. So sometimes these paracentral arcuate RNF layer defect, as we said previously, you can detect them using the 10-2. I'm stressing more on this point just to keep them memorized by heart. So sometimes also, as we say, the benefit of the total deviation compared to pattern deviation of the C reduction in the total deviation probability map, and you see normal pattern deviation, this means that the media is hazy. Could be due to cataract, could be due to corneal haze or corneal edema. However, sometimes this cataract with generalized field loss can obscure localized effects. For example, here in this example, the total deviation map is showing total reduction generalized field loss. So if you depend only on this map, total deviation map, you'll see, okay, this is due to cataract. However, when you look to the pattern deviation, you will see severe field loss. So sometimes cataract with generalized field loss can obscure the localized effect. So you need, in order to interpret the visual field printout correctly, to always read the total and the pattern deviation maps. Here, the RNF layer pattern is the nasal loss, as you see nasal stipping with borderline glaucoma hemifield test representing early or moderate glaucoma. Here you see that there is arcuate loss, okay, of the retinal nerve fiber layer with glaucoma hemifield testing outside the normal. Here you see that there is hemifield loss, and this is common in advanced glaucoma. This is the total deviation map. As we said, sometimes generalized field loss can be happen due to cataract or hazy media. However, the pattern deviation showing severe hemifield loss, which is common in advanced glaucoma with outside normal limits glaucoma field test, and minus 14.3 decibel mean deviation with very high 13.13 decibel pattern standard deviation. So please look at all these parameters in order to interpret the printout very carefully. Now, coming to the rule number 5, reaffirm the diagnosis. Please always reassess the retina and the optic nerve, seeking the consistency with visual field. You are not visual field interpreter. You are not AI model. You are clinician, physician, doctor, surgeon. So you need to read the visual field in the context of the patient examination. And please repeat the test if needed, and we will say why just in few seconds. You know that 85% of patients with abnormal fields in ocular hypertension study, they turned out normal after retesting them. So please repeat the test if needed and reframe the disease severity if appropriate. Okay? So always reaffirm the diagnosis, confirm abnormal field, even in experienced field takers. As we said that 85.9% of abnormal fields reverted to a normal on subsequent testing in ocular hypertension study. And this is one example. On 2nd April 1997, one of the patients showing inferior field effect, and when they tested after 1 week, it reverted to normal. So please repeat the test if needed. And why we should reaffirm the diagnosis of each patient? Because we have factors that affect the final result of visual field. We have factors related to the patient. Some patients, they have variable attentiveness. Some patients will be fatigable during the test. Some patients will fall asleep. Some patients are inexperienced with visual field testing. Some factors related to the perimetry, and the rule was, or the rule of perimetry was more important, the manual uh, visual field. However, in the automated visual field, the rule becoming less. However, they have very important role in counseling the patient, explaining explaining to the patient the test, explain where they expect to see the stimulus, how they will see it, uh, teach them when to stop and how to stop the test. These are very important factors during the test for the perimetrist. Also, the refraction, please always correct the refractive error. If the patient has refractive error and you didn't correct it, the patient surely will have reduced visual field, loss. So please correct the refractive error. Also consider presbyopia. And sometimes there is lens rim artifact when you, if they are too far from the lens, okay, they will not see the triggers that are touching the periphery, so it will show the lens peripheral field loss because of the lens rim artifact. So please consider all these points before getting final results from this printout. Also the pupil size, because if you have a small pupil, the light that entering the eye will be much less. So the sensitivity to the stimulus will be much less. Okay. This is especially when the pupil size less than 2.5 millimeter or less than 3 millimeter. And we said in the previous rules that you should you should check that the correct test has been done during the pupil size should be always more than 3 millimeter. Okay. Now we have just a summary of how to interpret the visual field. If you see that the MD mean deviation is normal and the corrected pattern standard deviation, which is, as we said, the short-term fluctuation corrected to the pattern standard deviation normal, and the total deviation plot clean, the pattern deviation plot is clean, so this is normal diagnosis. And if you see that the MD is abnormal and the corrected standard pattern deviation is normal, with many abnormal points in the total deviation plot with a clean pattern deviation plot, this means that there is generalized loss of sensitivity, like, for example, cataract or hazy media. But if you see that there is normal MD with abnormal corrected PSD and abnormal total deviation plot with abnormal pattern deviation plot, is most probably glaucoma due to localized effects, okay? Or localized effect due to glaucoma or other causes. And if you see that there is abnormal MD with abnormal corrected PSD with abnormal total deviation plot with abnormal pattern deviation plot, this means that you have both generalized and localized effects. Okay? For example, this can be happening in advanced glaucoma. We have just final touch to conclude uh, the reading, the interpretation of visual field, the Anderson criteria. This is very important criteria, perimetric criteria for the diagnosis of glaucoma. So this Anderson criteria has 3 points in order to say that this patient has a glaucoma depending on the perimetry, okay, only. The first point, that pattern deviation probability plot has a cluster of more than 3 non-edge points with probability less than 5%, at least one of them 1 point with probability less than 1%, which means that one of them, 1 point, it has 99% that this point is abnormal. Okay. with pattern standard deviation probability less than 5%, with the glaucoma hemifield test outside of normal limits. So if you see these 3 points together, this is confirming perimetric diagnosis of a glaucoma. Okay, depending on this, some authors, clever authors, generate a web application for automatic classification of the glaucomatous visual field using Anderson criteria, and they name it as a glaucoma field defect classifier. They have the website, and their paper was published in Nature Digital Medicine Journal. And you will see here like the website. You will upload the pattern deviation plot. This is the link of the website. Okay, and then you will write the mean deviation, the global plot central decibel values, and the visual acuity option, and run analysis, and they will say you most probably this patient have glaucoma. Okay, now coming to the case studies, we'll explain some case studies in order for you to memorize by heart how to interpret a visual field, collecting all the data that we said in the previous slides. The first case, you have 57-year-old man with no complaint, vision 6/6 both eyes, with IUB 22mm mercury in both eyes, and small disc size with no cup. You will follow the 5 rules that we introduce and how to interpret the visual field printout correctly. Okay. First rule is this the right test. Okay. So you will check here the field size central 24-2. You will check the stimulus size 3y, the background 331.5 positive. The strategy set a standard, the pupil diameter 4 millimeters. There is a refractive error, and the left eye, the age of the patient, and the date of the birth. Or was check please this is the right test was used. Second rule, the reliability. You look for the reliability indices on the up left corner of the printout. You will see the fixation loss. Yes, almost no fixation losses. The false positive rate and the false negative error rate. Okay. Then, so in this test, the reliability indices telling that this visual field is reliable. Then you will review the probability plots, the total deviation, the pattern deviation. You will see here that you have field loss nasally, okay, nasal step, and the total deviation and the pattern deviation map, okay, with many of them less than 1% probability. And these patterns of the retinal nerve fiber layers, nasal stepping, we call it, and the 5 rule reaffirm the diagnosis. This is moderate glaucoma, okay. And you can look for the other parameters we said here, the glaucoma hemifield test outside the normal, the mean deviation, and the pattern standard deviation. Please, if you watch this YouTube lecture, you will explain every point in this printout. Okay, please be focused. The second case is a 40-year-old man with vision 6/6, IUB 25mm mercury in both eyes, with average optic disc and superior inferior rim thinning. The first rule is this the right test? Okay, this is 24-2 threshold test. What are the other parameters? The stimulus size, the background, the strategy, the pupil size. You will follow. You will check all these points before reading the printout. Then you will go to the reliability indices, the fixation losses, the false positive, false negative rates. You will see them that this is reliable. We said that fixation loss ideally should be less than 10%. False positive, false negative should be less than 33%. Ideally should be less than 25%. Okay. Then you will go to review the probability plots. You will see that there are some unspecific changes in the total deviation plot. However, the pattern deviation plot is clear. You will check the retinal nerve fiber pattern, retinal nerve fiber layer pattern. You will see that the glaucoma hemifield is within normal, and you reaffirm diagnosis. This is normal, standard, automated perimetry. Okay. So you now understand every point in the printout. The case 3, this is 58-year-old man, seen 9 years ago with IUP between 24-28, average disc, visual field normal, and present for follow-up with IUP 22mm mercury both eyes. Now we'll combine between the two lectures I presented, between the 5 rules for assessment of the optic disc in glaucoma and 5 rules of interpretation of visual field printout. The first rule, you will observe the scleral ring in order to identify the size of the optic disc. Then you will identify the size of the rim, the isn't rule. Then you will examine the retinal nerve fiber layer. Then you will examine the region of parapapillary atrophy, beta zone and alpha zone. Then you will look for any retinal or optic disc. Okay, so the first rule, see the scleral ring rim. This is average disc size. Then you will see that there is inferior retinal nerve fiber layer thinning, inferior notch, so there is not rule violated. Then you will see there is diffuse retinal nerve fiber loss. There is no retinal nerve fiber loss at all in this image. Then you will see that we have beta zone parapapillary atrophy. This is the beta zone parapapillary atrophy, and there is no disc hemorrhage or even retinal hemorrhages. Okay, now this is clinically a glaucoma. However, combining these 5 R's of the optic nerve examination visual field interpretation, you will check you did visual field for this patient. You will check this is the right test, OCS 24-2. You will go through all these parameters to check that this was the right one to use. Then you will go to the reliability indices, fixation losses, false positive, false negative. You will see that this disc is reliable. Then you will review the probability plus both the total deviation, pattern deviation. You will see nasal sieving. You will review the retinal nerve fiber layer and see nasal sieving along with glaucoma hemophysis outside the normal level. So this is moderate glaucoma, combining both the optic nerve examination and a visual field. So this is the final printout. As we said here, the reliability indices data, relative fixation loss, false positive, false negative. This is the related to the right test, the test duration, the test strategy, the stimulus size, background, the pupil diameter, the visual acuity, the date of the test, the time of the test, the age of the patient, and then you will see the threshold numerical probability map and the grayscale map. Here you will find the total deviation map along with the pattern deviation map and the grayscale maps. Here you will see the glaucoma hemifield test along with the visual field index, as we said, the mean deviation with the pattern standard deviation, and here at the bottom of the printout you will see the gaze tracker. And now, by ending this lecture, you are able to understand every point in this printout. So please read it and memorize it by heart, and you need sometimes to repeat it. And thank you all. What I give in this lecture is only the tip of the iceberg, and there's too much data about perimetry, the other types of perimetry, and the diagnosis of glaucoma. Thank you all for listening for this interesting, very important lecture.